The business side of healthcare is horribly broken. So it really came down to building a business in healthcare that could solve for the business problems of healthcare, which is it's really hard for providers to get paid. And as a result of that hardness to get paid, the buyers of that care, which would be employers and employees, the cost of that care continues to rise because providers are trying to solve for the problem that they can't get paid. And they have to make up for it for people who are paying.
Thanks for tuning in to the Self-Funded with Spencer podcast. Let's go make healthcare better together. You're with Nomi Health, and you are the CEO and co-founder?
I'm the Chief Operating Officer and co-founder.
Yeah, COO, excuse me, I meant to say that. And so appreciate you coming down from Salt Lake to lend your voice on the show, man. And you were telling me earlier that Nomi is no middleman. Is that what it stands for? Is that tongue in cheek, or is that literally?
No, I mean, as we were looking back as we started this, we just felt like what we were doing was removing all those unnecessary intermediaries in the process of how healthcare on the business side is delivered. And no middleman. It just felt like just the right fit. So that's the genesis behind the name.
Well, very cool, man. Well, let's get the genesis. But if you will, Josh, just to start the show off, give us the elevator pitch of what Nomi is and does, so the folks that are listening will go, oh, okay, that's what this episode's going to be about.
Yeah, absolutely. Well, thanks for having me. Yeah, so as we mentioned, it's been fun to spend time this morning with someone who else is very passionate. And I know that a lot of your listeners are really passionate about sort of healthcare and what can be done about it. And the genesis of Nomi really goes back to just this dynamic, which is when you pay cash for healthcare, some sort of cash equivalent, the price of healthcare drops substantially. Substantially meaning 30% or better. Mm-hmm. That's without any negotiation. And so it really came down to, why is that the case? And as we've sort of pieced this throughout the years, it really came down to the fact that there are two sides of healthcare. One is the clinical side of healthcare and the business side of healthcare. Mm-hmm. Clinical, great. We have some of the best healthcare in the world here, right? Arguably, people fly from all over the world to get clinical care here. But the business side of healthcare is horribly broken and is really designed on the backbone of a system that was, it's 30, 40, 50 years old. It was designed for very different purposes. So it really came down to building a business in healthcare that could solve for the business problems of healthcare, which is it's really hard for providers to get paid. And as a result of that hardness to get paid, the buyers of that care, which would be employers and employees, the cost of that care continues to rise because providers are trying to solve for the problem that they can't get paid. And they have to make up for it for people who are paying.
Yep. And I think the one thing that I think will come out during this discussion, which I brought up to you, is something that I've recognized as well, that is a correlation between the college tuition growth as well as the hospital services growth, is that there's a large component of administrative share of dollars on payroll that are going to the administration of those systems. And you would argue that we can eliminate a very large percentage of that administrative burden or bloat just by being more efficient in the way that we charge and collect payment. And I'm with you there. That's a rational way to transact. And I love anything that helps us get a little bit closer to that. But you didn't just wake up one day and start Nomi, right? You have a backstory, Josh, that I'd love to get into a little bit, that includes some global travel and standing up businesses within United Health Group. So give us your kind of foray into the world of healthcare. How'd you get into this business?
Yeah, it's been a fun journey, like most of our journeys, right? You wouldn't connect all those dots initially, but it creates this wonderful path of sort of professional careers and opportunities to grow and expand. And for me, it started early on in healthcare, which was just a desire to go into the medical side, right? To become a physician, which led to me, as we discussed earlier, to a path where I was introduced to the business side of healthcare and found that really interesting and the opportunity to sort of solve for that. I spent a good chunk of that time at United Health Group in the parent company, right? Many of us are familiar with United Healthcare and Optum. Really learned what I would say from the inside of the belly of the beast of like, how does healthcare come together? Who are the players? What are the components? What are the parts? What's being spent and where are the problems that are being solved? And so I spent a lot of time, in that role, but also, as you mentioned, globally building and running our businesses internationally. So I spent a lot of time in different corners of the world and got to see how healthcare was put together. One of the exercises when running our business for the Middle East in North Africa was an exercise to help a country bring a privatized system to their country. Mm-hmm. And so it put me on this personal path of, if I were to rebuild healthcare from scratch, what would it look like? Yeah. And so I became a student of sort of global healthcare programs and really started to look at and form my own personal opinions around what were the best parts and pieces from around the world and how would you put that together. that path, as you fast forward it, really sort of led to, my partners and I coming together to form Nomi and an understanding of the dynamics inside the US market. What are the best ways to put this together? I'm an employer as well, right? We have a team of people that we help provide healthcare benefits for. And so taking that knowledge and experience and saying, okay, how would I build it based on what I know? What would the things I put together that would drive the impact I want, which is great accessibility, high quality care at a much lower cost than is available today in the status quo. And that's really what led to Nomi Health. Now, my other partners have their own personal experiences around how they got here, but the combination of those sort of experiences and sort of superpowers coming together is really what formed Nomi Health.
Yeah, and we may spend some more time on this later on when we zoom up and talk forward-looking about healthcare. But are there a couple things that stand out to you of other countries doing certain things that you think the U.S. system could learn from? Because I don't think anybody believes our system is perfect, you and I both included, but the other versions also are imperfect as well. Yet chances are they've probably solved pieces of it that actually are pretty compelling. So is there anything that stands out to you in that regard?
Yeah, I think that data is a big problem, right? We start with just the fact that we have a really hard time in healthcare communicating, sharing information. Part of that is the proprietary nature or the believed proprietary notion of data. The other is just the formats. So much time is spent just synthesizing data into the format it came in to the format it's needed to do the next thing. Now you add 14 or 15 different intermediaries into that process, and that adds a ton of business friction. So that's one amongst other things I learned, particularly in the Middle East, which is we started standing up that healthcare system on the privatized side with a single unified data format across the entire country. All parties participating in that had to use the same format. It was comprehensive in nature to meet all the different components and needs, but it was both the payments and business side as well as the clinical side. And that in and of itself had a huge improvement on just the throughput of just data exchange. And whether you decide whether it's proprietary or not, the ability to have systems talk to each other took a huge burden off.
Well, I imagine, building with a clean slate makes it a lot easier when you're centralizing and normalizing data. Having it start and always pass through one system makes it a lot easier because we have such a bifurcated marketplace right now of just all these disparate things that maybe do or don't talk to each other. And then new ones are stood up every day that then have to backfill to go back into whatever the centralized command center is. And it just becomes this really hodgepodge of different systems talking to each other. Well, what did they learn or what did they think about the U.S. system that they wanted to apply to their more public version, right? Because you mentioned standing up a privatized healthcare system. So they're obviously looking at the U.S. and saying that we could probably do that over here as well. Yeah,
I think one thing that we worked with and borrowed from the United States was a unified sort of coding system, which is like CPT codes, ICD-10 codes, that type of structure, which is like, how do you communicate what services were provided in a systematic way? Some of these countries where they're coming from different approaches just didn't allow for that kind of unified framework. That was one. I think the other thing was part of the reason these organizations were moving beyond the way they had it was that it was public healthcare. So if you were there, you just got healthcare paid for free, right? In the US model, we have other parties that are responsible for that payment, which I think is something that, as you and I discussed a little bit earlier, which is bringing a bit of free market dynamics or much more free market dynamics to healthcare creates great incentives for all parties that are participating. So that is another area I think that we brought to the table in some of these countries where I've operated. Also, looking at some of these other systems, as we talked about some of the developing nations where you wouldn't necessarily look at it, was the efficiency of how accessing services inside a hospital. You just showed up, you got the service, and you paid cash, and you walked out the door, and that was it. I think we underestimate the tax that puts on our industry, not only as business operators, but also as patients, of just having this sort of mental load of like, and I'm going to get a surprise bill sometime later. I sought a service, but I went into it with a little bit of trepidation. I needed that healthcare service, but I have no idea what it's going to cost me. And then over the series of the next, call it 3 to 12 to 18 months, I'm going to get random bills in the mail. Some of them are bills. Some of them say this is not a bill, but I can't really interpret it. That you don't see that in a lot of other countries where it's much simpler.
Having spent years working alongside healthcare leaders, brokers, and employers, I know how overwhelming healthcare can feel for our customers. We've all been there. Those renewal conversations that never seem to get easier.
rising pharmacy costs and medical costs, and no real transparency into where healthcare dollars are going. That's why I'm excited about Nomi Health. They're not just fixing the old system. They've rebuilt self-funded benefits from the ground up. With Nomi's network, you can offer something truly different. No copays, no deductibles, zero out-of-pocket costs when members see a provider. It's the kind of benefit that makes everyone ask, why hasn't healthcare always worked this way? Ready to bring your clients something different? Visit nomihealth.com and see how Nomi is rebuilding healthcare, one employer and one community at a time.
Well, it's just the anxiety that comes along with that unknowing, right? And we talked about this at length over coffee, is that we both believe that if you arm people with the correct information and make it very frictionless to access that information, most likely they're going to make an intelligent decision of how to consume care. The reality is we're incredibly far off from that being an actual reality. And so then we have knee-jerk reactions. I'm in pain. I need an urgent thing. Wherever I can go, I'm going to go, and I'll deal with the financial implications later. And so that lack of rationality in that choice, but because it was an emotional decision and it was a very urgent decision, I made it, understandably so, in emergency situations. Now we have the result of, oh my God, I can't pay for this. What am I supposed to do? Right. And I can't make sense of all these bills coming in. I now know, thousands of dollars. Who can even help me? And then you almost feel like you're at the mercy of this really complex system that you don't know how to navigate. And so I imagine that kind of understanding as you sat down with your business partners to say, hey, what are we going to build and what is it being built for? Give me the kind of the coalescence of the actual business of Nomi, like where it actually originated from.
Yeah. The origination of Nomi really stemmed back to this dynamic, which is it's really hard for providers to get paid. But more importantly, when you're able to solve that problem for a provider, the fundamental cost, we call it the true cost of care, emerges.
Okay.
And so when you solve for that payment transaction, so if you and I were to show up at the doctor today, and we talked a little bit about this, but just that it's even now it's hard to navigate the conversation. But if I were just to give you a cash equivalent today, all of a sudden that price is much simpler. The provider's needs are met, yours as a patient's are met. And so really Nomi's genesis was around how do we build that type of free market sort of direct relationship between the buyer and the provider in a way that can be scaled nationally. And that's the, to use a coding term, right, or a tech term, like the kernel that really was at the core of what we're doing. Okay. Then it was building, in addition to that and around that, the other things that would be required so that people could buy and consume this. We often talk about, or I do, not everybody is a car aficionado where they're buying specific pieces in the building of the garage. So there's a certain amount of pieces you have to have together so that most of the buyers of this type of service can buy them, right? You're not out shopping for a steering wheel. Well, maybe you are, right? But like most people need. If you're shopping
for a steering wheel, it's because you're replacing the one that's already on your car, right?
You usually need an engine and a steering wheel and doors and wheels. And so putting those pieces together in a meaningful way so that, me as an employer and my fellow employers in the United States have something they can consume and buy and drive today.
Well, but how do you go about really the crux of this is getting access to the information to know what things actually cost, which is the trillion-dollar problem to solve. And so how did Nomi go about finding out, well, what is the average cost or what is the true cost of this procedure in this geography? Because if that information was already readily available, your business wouldn't need to exist. So how did you mine that information?
Yeah, for one, I've had the luxury of a past life where we were building high-performing neural networks for the industry, and we had to really understand what the cost of care was so we could negotiate with hospitals and providers around what the right rate was so that they were getting a good price, but also the employers that we were supporting were getting a good price. And so it really comes down to a lot of data being aggregated. Some of that is data we buy that's available to pretty much anybody in the industry. But it's really around the secret sauce of how you bring that data together in aggregation. This is also one of our biggest rubs, which are self-funded employers, we believe, own their own data. But the industry continues to treat them as if two things. One, they don't own it. At best, they're a co-owner, right? And two, don't worry, healthcare is so complex, you won't understand. Let us take care of it. And so we are actively battling that in the United States in the sense of changing that paradigm and that shift in a way that we believe that the owners of the data are the employers and they should be able to do what they want with it, right? And so back to your question of what do we do? It's a combination of proprietary things where we bring data sets together to triangulate and understand price points in a marketplace. as well as using commercially available and public available data to do the same thing.
Well, so give me a somewhat of a reference point. And a lot of folks that have listened to the show understand reference-based pricing because we have a proxy for what it should be paid based on Medicare plus a margin, right? And then you talked about cash or cash equivalent. So a lot of folks, again, listening to the show might be aware that you can ask for cash pricing. And usually you can find out what their cash price is. Sometimes it's better than the network contracted rate. Sometimes it's not. But we're fishing for price discovery in some way, and we're using different benchmarks to try to get there. But you mentioned triangulating it into getting to an actual true cost. How do you assemble all those pieces together?
So I think that you start with our goal, which is in any given market where we're operating, and when we talk about our rates with providers, we try to beat the carrier rates by 22 to 30%.
Okay.
And so when we say carrier rates, I'm not looking at like the most expensive carrier on that rate and trying to beat that. That may not be a good deal for some employers.
Because some of the other carriers are probably doing that.
So we look at the lowest allowed amount average. So whoever the carrier is in that market that has the best rate, that's the goal we're after. That's the number we're trying to beat. And really it's that combination of the data that I mentioned earlier and how we synthesize and understand that data to triangulate exactly what that rate is by CPT code or bundles, as you can imagine, right? Hospital charge masters are complex. So really understanding, we look at, we call it a kind of market basket of services of consumed medical healthcare in that market and say, okay, under this framework, does that beat the market rate?
Okay. So the lowest average allowed amount, okay, then you're trying to beat it by 22 to 30%. How does that typically compare to the cash price that might be offered for that service?
Yeah, so I mean, the goal for us is to bring those together, which is the consumer, in this case, the employer, is getting the lowest net cost regardless. So we take into account the machine readable files and these sort of cash prices that are available to make sure that when we're having those conversations with the providers, it's all encompassing, right? What we're after is a favorable relationship to both parties, right? We're solving a problem for the provider. So when we engage the provider, it's not your usual dynamic. We're not I often say we're trading on a different currency. Typically when you go to a provider, in the traditional space, you say, I'm large insurer, I have lots of lives. If you don't give me a discount, watch out. And there's sort of this strong arming. We go to providers and say, hey, we're trading on a different currency, which is, for one, this is a collaborative relationship. We're trying to help solve for the problem. It's really hard for you to get paid. When we do solve for that problem, we think it's worth this value. What do you think? We come and have very deep financial conversations with the hospital around their payer mix, their spend, their price point, with their cash rates. And we say, what's the value of that? And that's really how we triangulate the rates with the provider. And we come out the other side with a collaborative relationship with providers in a way that we're solving jointly the problem and creating a lot of wonderful downstream derivative sort of opportunities for those who are participating.
Yeah, in the interest of collaboration then, because on the surface you hear driving down the price significantly, which the consumer would say, great. Provider may not agree so much, right? And you often will hear that even Medicare reimbursement rates sometimes are purported to be too low, and we can't build a business, so we need the private sector to subsidize our Medicare reimbursement rates. The reality is it sounds like you're probably even driving price points down perhaps below Medicare in some situations, yet you're saying that collaborative and the providers are still happy. Yeah. How have you achieved that then?
Well, so to answer your question, I think part of the conditions that are set are the fact that whether you argue that Medicare is the right rate or not, I think most providers and probably most people would say, well, that's probably not the right price point because it's based on a static-based budget, right? The federal government has a budget. They look at all the codes and they say, okay, let's spread the dollars around. I think that's partly rub number one.
Okay.
And it's not that the federal government is doing a wrong thing. It's just that that's how they have to work through that. But it's also in the exact same reimbursement model that is commercial insurance today. So if you have a ton of overhead on administrative overhead and just trying to get paid, pre-authorization, medical necessity, fighting a bill, nurse case managers, DM, UM, CM, you go through the acronyms of all things that are baked into like a provider trying to get paid. When you remove that or streamline those pieces that remain, it actually changes the cost profile of delivering that care. So then you look at the market and you say, okay, what price point's the right price point? Well, let's not use market as a reference. Let's say, now when I've solved that problem, provider, what's that worth to you? And in our model, it could initially, until you understand it, it feels initially like we're asking the provider for this massive discount. which if you used the commercial rate or Medicare or whatever, it does feel that way. But when you actually do the math of like, okay, you get rid of that 25%, 22% administrative overhead in that dynamic, it fundamentally changes how the hospital spends their resources, their time, their energy. And so instead of getting paid, 75 cents on the dollar in today's commercial contract, you'll make, 88 cents or 80 cents on the dollar. Providers got a pay raise, all the headache. They're like, that's the right price point for me, because we call that the true cost of care.
Well, I didn't know that stat you just referenced, 22 to 25% is administrative overhead, if you will. That's an astonishing percentage of a hospital system, I would say, that goes towards administrative burden. And I think you referenced one where there was like 2,500 employees in one system that were doing billing, which is crazy, right? I don't imagine the actual payroll implications of those 2,500 people. And I'm not saying they're unnecessary or shouldn't have their jobs. What I'm saying, though, is that is a huge proportion of your business dedicated to administrative overhead just to procure payment. So what if we could wipe away a significant portion of that and just directly do business together? And I would say the proof is in that these providers are signing contracts with you, because you've been able to compel them to say this works. And I'm sure over time you obviously prove it, or they wouldn't continue to contract with you. And what we're really at the core talking about is a more efficient payment methodology that makes everybody better.
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans, and allowing them to create an environment where we ensure that the benefit plans are being charged on a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
But it's not just the price, it's the actual payment rails themselves, right? So how are you assisting in the procurement of the dollars in that transaction too?
Yeah, so I think, when it comes to just the value of, how we pick up the dollars, it works a lot the way it does today, right? So because we are the Amazon, think of the Amazon Web Services as to cloud computing, we're the underpinning sort of new infrastructure. We still work with many of the parties involved, right? So a customer will often still be working with a third-party administrator to adjudicate and administer the claims. Once they've done their adjudication, that 835 gets sent to Nomi. Nomi processes the payment. We're able to do that very quickly. When it's a provider that is within our network or where we have a contracted relationship with, the TPA would get the 837. They immediately send it to us. We reprice it against our contracts, goes back for adjudication, then comes back for our payment rails, and sort of moves from there. The dollar flow is the same as it is today, right? Typically, a third-party administrator works with their self-funded employer. They decide on what the run rate is on average, whether it's weekly or biweekly or monthly. They've pre-funded a bank account. Nomi has a health trust where we can hold those dollars if they'd like. But at the end of the day, we work with whatever banking partner they have.
Okay.
And so we work with the TPA to draw those funds and make that payment immediately when all the decisions have been made around the payment.
Well, and what I'm hearing from you, and let me ask you this question, is if you're assisting with the price discovery to really get a true and fair payment amount, you're assisting with the payment processing and working with the TPA in order to follow the normal process today of collecting the cash. Do we need networks anymore? Or are we ultimately moving towards a world where what you think of as a network is somewhat obsolete?
Yeah, I love that question, Spencer. I think I believe long-term, no.
Okay.
I think today we call it a network because that's the way that the market has to understand and consume it, because we've been so programmed, whether that's patients or employers, of like in network, out of network, you get multiple tiers in some cases, you got special carve outs. It's become so complex. I think in our world, right, and as we look back to the genesis of Nomi, this is just a way to pay all providers more efficiently, which elevates the entire industry and entire market, not for the sort of haves and have-nots, right? The goal would be long-term. To your point, I don't think we need networks. I think we should be able to buy healthcare the way we buy most other things.
Yeah, the notion of we'll bring volume for a deep discount, I think that original idea is so far morphed into something that's almost unrecognizable at this point. And I have found myself for the last couple of years questioning the validity of a network anymore, especially when there's 99% overlap in the providers and network. They're all within margin of error of each other on pricing on aggregate, not in each individual claim, but in aggregate. And so what value is really being derived from an employer's perspective by using a UHC network or an Aetna network or a Blue Cross network? At the end of the day, I don't know if they have the same level of value in the transaction as they used to. But then we haven't gotten to a point where a full replacement at scale across the country to everybody has existed. Reference-based pricing has attempted to do that. You have these high-performance narrow networks, which you described as well. But we haven't turn something on that in one fell swoop makes the traditional network obsolete. So is this something that we're still a matter of years, in your opinion, away from fully being able to do across the country, even if it can be done in pockets today?
I don't know. Yeah, it's going to take a couple of years, right? But I think that we are pretty dedicated as an organization to building that infrastructure out. But you think about it, now our goal would be able to reach all Americans and make these tools available to everybody. But if you think about the industry from a standpoint, the top 30 MSAs represent about 72% of the US population.
Okay.
So you really don't need that many areas where you actually have to have this fully baked and ready to go, where the large portion of the United States healthcare system has been transformed overnight. And so we're not decades out, we're probably not even 10 years out, where this concept of really driving, a better way to pay, an easier way to pay, back to your network piece, which is part of the challenge. And this is my past life and sort of living in other organizations. This misnomer of economies of scale for discount, to your point, the networks, the carrier networks are now so deeply overlapped that if I come to you as a carrier and say, I want a better price because I have, 70 million, insured on the back end of this, I can't actually really shift volume because I now need everybody in that market, every provider in that market in my network, because I have so many products and so many network products and so many tiers. I can't actually shift volume from you to the other guy. So we've now sort of tricked, if you will, providers into giving, the industry's forced providers to give discounts for something that can never really be materially shifted to. So just another area where the market has just gone so far sort of afield from what it really should be delivering.
Well, and so let's shift gears a little bit into the world of Artemis. I think it's a good segue here because none of this is possible without truly enriched good data, right?
Yeah.
So tell me about the business unit that is Artemis.
Yeah, Artemis is a phenomenal organization. They've done a great job over the last, over a decade building a product that really helped take data into data insights and driving that towards actions and really helping build a framework and a technology that's nimble. We call them stories, but essentially dashboards, which is like what's really relevant to an employer. And it was really interesting. We were meeting with the CEO of a large theme park. And we were talking about their healthcare spend. And we said, okay, well, tell us about your healthcare spend. How much is it? And he's like, oh, well, it's about X tens of millions. Okay, well, where do you spend it? And he's like, well, what do you mean? Like break that down for me. And the more questions we kind of went down this path, the more he felt a little sheepish that he wasn't in touch with one of the biggest line items on his P&L. Said, okay, let's back it up for a minute. Let's talk about churros. Churros in the park. And the amount of detail he understood about churros and the best peaks and times a day and what their cost margins were per churro and the labor costs and everything went into it was like phenomenal. And so where I'm tying that to is that Artemis allows employers who are the ultimate fiduciary of their plan, their ERISA plan, to have the same dexterity about their healthcare costs as they do their churros.
Yeah.
And really understand the nuances of that and in a way that's digestible, where the industry can't just say, oh, it's too complex, you won't understand. Artemis elevates that into a state of like understanding. So we often talk about grounding everything in fact and truth. Before you start on the Nomi journey, it's grounding everything in fact and truth. Understanding where it's being spent. Then that derives what actions can be taken, where do you start and where do you go next?
Yeah. Well, I can envision a clip being what a churros teach us about healthcare analytics.
Yeah,
So we might have to make that clip.
That's a great idea.
But it's a fantastic correlation because you're absolutely right. We talk to business owners all the time at Pareto, and they will know every single nook and cranny of their business outside of healthcare, and then they just feel like they're at the mercy to that line item, and that's what my broker does. Or I don't know, the insurance carrier told me my rates needed to go up X. I don't know why, but that's what they said, so I've trusted them as my partner. The reality is if you actually show them what they're missing through a data analytics platform or being self-funded, they would go, how did I ever operate in this manner in the past? But you have to get them there to actually take that leap of faith. But what was it about Artemis? Because I believe this is a result of acquisition, correct? Right. So what was it about their tool versus the other ones that are out there that you felt was the right fit into the family of businesses?
Yeah, I think we look usually, we've grown both organically and inorganically through acquisition. We look for like-minded organizations who really fit the overall mission of Nomi, which is really driving innovation and accelerated action into the healthcare space in a way that results in the lowest net cost for employers and their employees. And so I think fundamentally, day one, there was high alignment there of like, what does the journey look like and what do we want to do together in the industry? What kind of change agents do we want to be? Second would be the innovation of their technology, their platforms, how nimble it was, their ability to ingest. We've got, I think now we're up to 17 or 1,800 data feeds coming from a myriad of organizations, point solutions, and you name the healthcare organization, we likely have that data flowing into the platform. So the ability to take in, as I mentioned earlier, some of the problems that other countries were able to solve for, every single one of those data feeds is different.
Yep.
Different format, different file, different header name, different structure, schema underneath. So that was the other piece. The other was then an organization that was ready to take the next step, which was not just showing a customer, an employer, where the spend was going, but was willing to sort of take action and move forward to like, how do we help the employer enter the broker or consultant that are involved there drive the next thing, right? And we chatted a little bit about just our ability to understand point solutions even. Which ones work really well within certain populations and certain cohorts, and which ones do not, right? We've been doing this long enough to really understand the nuances of different personas of cohort type organizations and what's the right application of tools. I feel like sometimes we're all on this journey as employers or brokers of like, well, that's a cool new point solution. Well, that sounds like a really great, let's roll it out and see, right? Yeah. We also have the ability, because we've been doing this long enough, one of the other reasons we picked up Artemis as someone who joined the family was the longitudinal data and experience they had. 25 million patients across all 50 states. We're processing enough data today that it represents somewhere between 5 and 7% of the U.S. labor force is moving through Artemis today. Okay. So it gives us this scale and the ability to do things with data and statistics that you can't do when you have small data sets.
Yep.
Pareto Health is the largest benefits captive in the United States. With nearly 3,000 captive members, $1.3 billion of stop-loss premium in force, and almost 1 million covered lives, no other benefits captive comes close to Pareto Health's scale. But it's not just about the numbers. Pareto Health is a mission-driven organization, and that mission has two distinct parts. Number one, to make self-insurance simple and more accessible for small to mid-sized employers. And number two, to arm them with the most powerful cost management tools on the market. So if you're an employer frustrated with your healthcare outcomes, or you're a benefits consultant looking for an alternative to the status quo, it's time to consider Pareto Health. Pareto Health, where employers come to do self-insurance right, to do it easily, and to do it at scale.
What I like hearing about what you're saying is the precision of application to a persona. So I think about the analogy with the, was it pharmacogenomics, right? Where so right now today, if you didn't have the pharmacogenomics data, your physician might prescribe a statin to you and not really know how you personally were going to be impacted by the statin and process that drug. Enter in pharmacogenomics, now I can tell you're a high metabolizer or a slow metabolizer, or you have some genetic predisposition where you shouldn't take it at all. That level of precision then shapes the recommendation that comes from it. I think the same thing is what you're talking about with these point solutions, whereas you just throw a bunch of them on and they sound great, and then you get zero utilization, or you get a bunch of confusion because there's 10 different things bolted on. Nobody uses it, and then it looks like a failure. But the reality is that you weren't precise in the way that you recommended or selected those things to bolt on. Yeah. So Artemis could help shape that. And how are you identifying those cohorts, like in separating them into different cohorts? What data points do you collect?
Yeah, so I think there are a couple different cohorts. One is the company level, the enterprise level. Like, what does this employer, what's their persona as an organization? Are they a to use a simple example, are they a Silicon Valley organization that has a bunch of 20-year-olds working for them? That's a very different cost profile than, say, a manufacturer in the Midwest that's manufacturing steel or other things like that. They're very different profiles of the population themselves and what the problems and the challenges are, right? So we look at the enterprise level. Then we have a pretty extensive clinical team that's also looking at sort of the best models, not only that are proprietary for us, but also in the industry, of like how to understand individual level personas. Like, okay, some of these we'd be familiar with, like musculoskeletal, diabetes, right? Those types of profiles that have a sublayer underneath that really help us understand sort of how to break down the next actions and build the stories, these dashboards that are relevant to the customer.
Well, and the point solution recommendations is likely a result of cost drivers that you've identified, right? So you said data analytics tools, there's a lot of them out there that collect the data. But what do you do with it, right? So whether you identify a diabetes, a lot of diabetics in your population, or maybe there's an overutilization of ER. I often use that as a source of kind of results of why claims are going up. Okay, now what, right? So is this a playbook? Is this some sort of like, hey, have you considered this? How are you helping an employer make sense of where those drivers are coming from?
Yeah, we break it down into two groups, which are, really what we call actionable overspending.
Okay.
Some of it's really interesting. There's not a lot you can do about it because either there's not a solution in the market or it's more sort of like a good to know in the industry. Then we break it down to these actionable overspending, which is things that you can actually take action.
Okay.
Whether that's you as an employer or broker can recommend to your or TPA to your customer of like, hey, we should go do this, or we should go find a point solution for this. Now, because we have so many point solutions in addition to the regular data feeds we have coming in, we have an idea and opinion about, in some cases, what might work well on others. The others are actually even outside of point solutions, right? Or other programs. Because we have the data we have and the longitudinal data set we have, we can also look at like the most popular one today, which is GLP-1s. Every employer is like, wow, that was not my budget. It totally crushed me. It was like the Hep C drug that came out, I think a little over a decade ago. It blew everybody's budgets out of the water. The question is like, do I ratchet it way down and put all this pre-authorization and qualifications that patients have to do before they qualify for GLP-1? Is this just a weight loss thing? Is this a diabetes thing? Is it a combination? Even if it is just weight loss, should I open it up?
Yeah.
Because we're seeing that there are all sorts of other indications that lower heart disease and kidney disease and all these other pieces. Well, it turns out because of the way we keep the data and we monitor and analyze it, we've been working with one of our customers who's one of the largest flooring manufacturers in the world, who were very forward thinking when it came to even the early class of GLP-1s. And what we've seen with that organization, and this is not a recommendation, on the podcast here, but just a representation of the things we can do with our data, which is we've seen actually, because they leaned into GLP-1s early. This is now about 8-year-old data. They've seen a precipitous drop in the overall cost on a PEPM or PMPM basis of the population because they opened up GLP-1s. Yeah. And had all these like derivative effects. Now we'll see longitudinally where that continues, but that's the kind of stuff we can do. And we don't just look at your data as a customer or your customers as a broker. The value we bring is we can look beyond that and look across the entire data set and say, what types of things are we seeing? Are you on par? You have some good references and data points where sometimes as a small employer, you might have 50 to 200 employees. Your data isn't even statistically significant on its own. So we're trying to make decisions. You are in this kind of silo around that. And you're like, I have no idea because there's not enough frequency in the data or the CPT codes to really get a predictive analysis of what's coming next. Artemis can bring that to the table because we can leverage learnings and experiences we have across the entire sort of continuum of what we see.
Well, with the size of your data set, it should be highly credible. Do you guys release any sort of annual report of what you're seeing in trends and things like that? Okay.
In fact, we release monthly and quarterly what we call trends and spends.
Okay.
It's just our observations of what we're seeing, which we think are interesting nuggets in the market, and as we look across, the patients and customers we serve, things that are notable. Right?
Are there anything outside of the GLP-1s which are pretty obvious that you're seeing an uptick in certain type of cancers or any? I mean, if you don't know a data point off the top of your head, didn't prep you for it, but I'm curious what you're seeing in the data right now.
Yeah, we've had some stuff around diabetes. We've had some around women's health. There's some pieces. I think we've released a few things about behavioral and mental health. Easily Googled. If you just put trends and spends and put Artemis or Nomi in there, you should be able to pop up what we've been releasing.
This. Yeah. Because I feel folks will often ask me, like, what are you seeing in the market, right? And I have access to the same information most people have. Obviously, I care about it and want to research it. But anytime I can get an extra data point, or HCC releases their stop loss report every year, I always like to dig into that to see what they're seeing, because then that's going to shape future decision making processes or recommendations as well. And so I guess maybe we shift gears, if you want, Josh, into the third core pillar of your business, which is the pharmacy side, which is really interesting and maybe even begs the question, why get into pharmacy? What was missing in your business before you guys acquired a PBM?
Yeah, I mean, it really came down to the fact that, back to my history, which is there were a couple things. One, medical and pharmacy seemed to be the two twins that were separated at birth that never should have been. You had two large cost centers. One can affect the other dramatically, right? A provider could write a prescription for, pick your favorite drug, maybe it's Humira, that's $10,000, $20,000, $60,000 a year, and have no idea that the PBM or the pharmacy benefit didn't allow that patient to buy that at a cost-effective way when there could be alternatives. Now, there are all sorts of ways we try to get in the middle of that and redirect scripts, one of which I did many years ago with the NHS, which was called Script Switch, which was our ability to, at the point of care, swap out a prescription for something that was more generic. Okay. The point being, the medical spend, medical benefit, inpatient, outpatient, huge cost driver on the P&L if you think about the aggregate cost spend of an employer. One of the other big categories was the pharmacy piece. So it just seemed like a natural to bring those two together in a more tightly coupled way. But also, none of us are strangers. Anybody listening to this podcast now knows, right, that there's been a lot of monkey business going on in the PBM space for a long time. And so we were really after finding and adding to the family an organization that saw it very differently, which was really driving towards, I used this term earlier, which is the lowest net cost. At the end of the day, if we all drive the costs down, we all win here when it comes to their abilities. So really that's what drove it, which is huge cost center for employers and those who help employers navigate that world. We wanted to bring that into the fold to have it more tightly coupled with how we drive those costs down.
Well, as a huge cost center, what are you seeing on average as pharmacy spend these days and most employers spend? Is it about a quarter or so of overall budget?
Yeah, it's between 24 and 27% of the overall budget is now pharmacy related. And that's just going to get worse.
Yeah.
If you think about specialty drugs, everybody's watching that. Oh, that's going up, right? That doesn't even take into account now all the gene therapies, and the other sort of amazing new technologies that are entering the pharmacy space, where some of these medications or therapies rather are in the millions of dollars, right? I mean, one that was just released at the beginning of this year, the sickle cell treatment, essentially a cure for sickle cell. The way it's shaping out right now is the medication, that the actual therapy itself is about $2 to $2.5 million. Then you layer another $2-ish million of inpatient / care needed around delivering the therapy. You got about a $4 million price tag. How does that?
How do we pay for that?
Right. Yeah. I mean, the industry can't even pay for that right now. Who pays for that? Is the hospital initially buy the therapy and then charge the employer? Does the employer go buy it directly from the manufacturer? Right. I mean, patients.
And this is the stop loss carrier's responsibility, right?
Exactly, because they'll hit all the,
they're going to hit the attachment
points, the thresholds.
So the question also becomes then, if there's truly a cure for sickle cell anemia, how do we not offer it to people, right? That's that dilemma that we're in. So these $4.5 million price tags, we're going, we can't pay for that. But then if it's a child or a human being that would greatly benefit, or there's a curative effect from this therapy, how can you deny them that simultaneously? And it's a contrast I don't think there's a good answer for. The reality is we're going to try to figure it out as an industry, but there's a lot of finger pointing about who's going to be paying for it at the end of the day as well. Or are we perhaps inhibiting people or making it harder for them to get access to it right now because all these steps in between to triage to make sure that the right patient? I don't have any good answer for that situation. But what I wanted to say about that in general is, I've heard since I've been in this industry, pharmacy is going to keep eating up a larger and larger percentage. But I remember 10 years ago, most of the clients we had, they were in the neighborhood of 30 to 35%. So I don't think it's wrong. I think what it under projected was how much medical costs were going to go up simultaneously. So the actual market share that I've seen over a decade is very similar than it used to be a decade ago. They've both just gone up an exorbitant amount simultaneously. So that's not to say that pharmacy isn't an important part of the spend, because very regularly when we bring customers into our platform at Pareto, the first thing we're addressing is pharmacy because it's the easiest thing to address and save money.
Chronic health issues, surprise out-of-network medical bills, inflated medical and prescription drug prices. These issues cost self-insured employers hundreds of millions of dollars every year. Add to this the rising cost of care and potential for waste across the life of a claim, and it's clear that self-insured employers need innovative solutions that lower their health plan spend. At Valence, we've done just that, developed innovation that shifts the current paradigm. A complete and integrated ecosystem solution driven by data, one that manages and simplifies the complexity of medical claim costs. It is through analyzing millions of data points that we enable employers to realize and fuel cost-saving solutions. Valence experts come prepared from day one, targeting the fraction of claims that will drive the majority of health plan costs. That is how our team lives the Valence promise, engaging early and often for smarter, better, faster healthcare.
But what you said earlier, you guys aren't a stop-loss carrier. You don't want to be a TPA. Why was it important, though, to have a PBM in-house?
I think it just came back to that comment I said about sort of the two twins separated at birth, which is they're just so tightly coupled. It's really hard. It seems to make a lot of sense in just when you're helping an organization tackle their healthcare costs to have much tighter coupling between those two things. Because rarely do you have one without the other.
True.
You know, in the sense of like a pharmacy comes as a result of a medical visit or some sort of therapy or diagnosis. And so really having that, under the one roof. And the other is just because we're after, including our own costs, lowering the overall costs, why would we leave one of the biggest contributors of the cost out of the equation of things that we can deliver to ourselves as an employer using our own products and services, as well as those that we work with from a customer standpoint?
What is the name of your PBM, though? We didn't say that yet.
Surpass.
So obviously you guys are doing the very core things that a good PBM should do. Lowest net cost, which anybody's not listening, you're moving away from maximizing rebates and setting up a formula to do that to truly driving to how do we get the drug at the lowest possible cost, right? Then you're moving into patient assistance programs, copay assistance programs, international sourcing, probably trying to eliminate spread as much as you can as well. Absolutely. And that is what, to me, the modern day PBM should be. It's not like, oh, that's a really good, cool new idea. This is what a PBM should be in today's world. And so you add that in the framework, and now you have this nice little 1, 2, 3 punch of solutions that you can provide for an employer. Well, what would stop you or prevent you from wanting to get into the world of being your own TPA? Why do you think that's an unnecessary part of your business?
Well, I think it's less about unnecessary. It's definitely a role that needs to be played in the industry. There's just a lot of things that TPAs do really well that we don't have any interest in doing.
Fair.
Nor do we need to. Those services are being provided out there, right? And so I think it really just comes back to just being this underpinning of sort of the new infrastructure for healthcare, for self-funded employers and those that participate in that space. And we're happy being that, right? There's plenty of opportunity there to disrupt and drive change in working with the partners in the organization or in the market that are already doing amazing things that provide additional services and programs to employers that they want on top of that, whether that's their, the UMDM or CM or their smoking cessation programs, or the list goes on of all the things that an employer may want and need to have that administer, run, and manage for them that they won't be doing on their own.
Yeah, and I didn't mean that as a probative question. I think what it really speaks to is there's still a desire for flexibility. I mean, it's the same approach we have with the business where you're not forced down a path and you either accept all this framework or you don't get to do business with us. The reality is there's a lot of different profiles of employers with different size segments, different needs, different goals, all those things. And so you have to meet them where they are today and then be able to offer solutions over time. In the interest of really identifying that, I think for the listener, it'd be really crucial for us, Josh. Like, what is an ideal customer of a Nomi? Like, who are you going after to partner with in the marketplace?
Yeah, I think as we think about customer profile, I think the first qualifier would be you need to be self-funded or working with an organization. Maybe you're level funded, which is a version of self-funded, where you're ready to take on more responsibility for your benefit spend and the benefits you're providing to your employees. Then I think you look at, are you willing to really challenge the status quo? Are you ready for that? I think that because what comes with that is some wonderful opportunities to have way better control of your spend, your cost, reduce your costs, enrich your benefit to your employees, which in today's world feels like a bit of a contradiction, right?
But we don't talk about it enough. You can do those two things simultaneously.
So I think you look at that, and then I think about, really understanding, is the healthcare cost of your P&L really impacting the business? Because some organizations, it's going up for everybody, but some organizations are like, yeah, but I make $1 gazillion anyway, and I'm worried about what 17 other things I put on my benefit plan to keep employees. Yeah, I mean, we work with those organizations, but they don't see as much sort of excitement in driving, that enriched benefit at a much lower cost. So I think, and we really are most focused on just America, like getting Americans better cost of care. So we fit really well with all sorts of organizations, but think about organizations where they do manufacturing, where the employees may not make crazy amounts of money, but still need access to healthcare. And these organizations find themselves caught between the middle, which is they can't increase costs because they can't take on the burden as an organization. Right. They can't pass the costs on to their employees because of the dynamics of the financials. They're kind of in this like really tough middle ground, which is I can't go forward with what I've got because it just keeps going up 4 to 6 to 7 to, we just saw in one of our states an average of a 30% increase in premiums across a whole tranche of employees. I mean, I run a business. It's just you can't take that kind of stuff on. I mean, it's just,
and especially 30% out of nowhere, right? Like you could understand if over time you were hearing that this is going to be the outcome and prepare for it. When it just happens and the cost of this one line item, like you said, is the second largest usually, just goes up 30% overnight. Most business owners can't sustain that type of increase. Right.
Yeah. And I think the last would be, you can't be the kind of person who just kind of wants to put the head in sand and be like, I don't know, throw my hands up. I don't know what I'm going to do. The customers who do the best with us are ready to take control.
They're involved. They want to be proactive.
They want to really understand. They want to pop the hood and see what's inside of this thing they've had for the, name your number of years and really understand the components and are willing to start to take action against that.
Is there a size segment that makes the most sense or a floor or a top end that would restrict the ability to partner with you?
We work with organizations at all sort of levels, tens of thousands, hundreds of thousands of employees all the way down to 50, and that, so in fact, I think we have some organizations that are smaller than that, right?
Yeah.
So our goal was to build a solution that could be consumed by the market in general, just to help us all.
Well, and I think that, honestly, this is where the marketplace is going. And there's a reason why this is a self-funded with Spencer podcast and a joke, not the fully insured with Spencer. But it's not just self-funding. I think self-funding is the initial step to then make all the stuff that you and I just discussed over the last 45 minutes possible, right? If you don't self-fund, you don't have the flexibility to do hardly anything that we just discussed. And so therefore, you are going to be constrained about what you actually can and can't do in your plan. But you self-fund first, and that's not the end. Then it becomes, okay, well, how do I get access to better enriched data that I can take action on? How do I get access to better pharmacy contracts and pricing? How do I have access to a high-performance network that's been already stood up for me and I simply can lower the cost of medical claims in a frictionless way? Those things are enabled by the very first step, which is you have to go self-funded. And it usually means you also need to self-fund with an independent or some semi-independent third-party administrator. You need flexibility in the framework of your plan. And I'm fully comfortable with the fact that that's not going to be every employer.
Agreed.
And maybe it's not every employer right now, but a lot of them are go, well, that just sounds like a lot of work. And I don't really have enough pain right now to feel like I need to do it. But those that are willing to lean in and open their eyes to this kind of thing actually realize, I think you can truly turn your benefits plan into an asset and not a liability, meaning you can attract good employees, you can retain them. You actually have this paternal thing where you're providing rich benefits to people that make their lives better. They want to work for you and they're passionate to go to work. All of that is possible if you first self-fund, right? And I'm not saying you can't do everything, but you can't do any of these things if you don't do that first step. And so then I ask you a question here, Josh, as we sort of zoom out, which is, All the things that we just discussed sound amazing, and I have no doubt that you guys are delivering on the promises. Where are we going as a healthcare system? Is it a matter of staving off single payer, or do you think we're going to have a health system in the United States in the next couple of years that we're actually proud of as a country?
I think that's up to us as an industry, and quite frankly, as self-funded employers, right? As to where do we want things to go? And I think it really comes back to the opportunity is there for us to take charge and control and really drive that to where we want it to be. Now, whether we end up with a single payer system or not, I can't predict the future.
Yeah.
But what I can tell you, of the $4.5 trillion that's spent in the United States healthcare, just short of a trillion of that is like the commercial side of the industry, and 846 or 47 billion last I saw was actually the self-funded spent.
Okay, so employers make up $1 trillion of that $4.5 trillion, and then 800 and how much?
47 billion.
So let's call it 85% of that trillion are self-funded employers.
There's no reason we can't make this what we want as employers.
Yeah.
To change the trajectory, to sort of push off and shed, as we say, take control of your spend. Let's do something about it. Let's no longer be sort of subjects to the status quo, the solution takers versus the solution makers. And that's really what drives us as an organization, is to I am building not only what I think is right for the market and the industry and other organizations like ourselves, but what's right for Nomi as an employer and for our employees, right for me as a patient and my kids who are on our plan and access physicians. We purposely use our own solutions for a number of reasons. One, really helps you understand whether you're delivering the right value, because we're also an employer. Two, what enhancements and changes do you need to make over time to adjust to new market conditions and circumstances? But the third, it's saving us money.
Yeah.
I mean, it is. There's not a better way for us to do that. Then we can take those dollars and put them right back into the business and into our employees and help us navigate.
Well, and one of the things that you said over coffee along the vein of saving money is you guys actually ultimately switched over to like a zero out of pocket or deductible plan, which is counterintuitive to most people to think, wait, you remove any of the cost share from the employees altogether? That's obviously going to make your costs go up. And you said the reality is you actually saw the opposite be true, right?
Yeah.
Why do you think that is?
It's interesting. We're asking ourselves the same question, right? We believed it to be the case as we started this journey, but we're seeing in the data it should prove out. I mean, there are, I think, a couple things that underpin that. One, once you relieve the stress of accessing healthcare, people actually access healthcare, but not the kind of healthcare you're worried about as an employer. It's not like, I think you have to start with we're like, oh my gosh, it's like the run on the candy store.
Yeah.
Like candy's free and everyone shows up. I think about my young kids and of course they'd go consume as much as they can. None of us want to actually consume healthcare, meaning it's not like a fun thing to go to the doctor.
Well, yeah, you didn't remove a deductible and somebody goes, oh, thank God, I'm going to go get my lung transplant now.
Exactly.
Right? Like that's not like they're rushing to do that kind of thing. Yeah.
Exactly. So I think we need to come at it with sort of sense of common sense. Nobody's it's not like a party to go to the doctor. So you're not just out there it's free, let's go, you know? So you've got that. Two, the care you are accessing is the care that we've been trying to incentivize employees to do all along, which is preventative services. Most plan design states in America have that as a fully covered benefit, right? It's 100% covered by whoever's providing the benefit plan. That's the stuff that we're taking that mental load off of patients, but they're not fearing the bill. There's some interesting stats that when we started Nomi initially, it was something like 75% of Americans fear the bill more than the actual procedure.
Yeah.
They're terrified of what it's going to cost because they have no idea. It's like going to Costco and buying a TV and not knowing whether you got the $10 TV or the $10,000 TV and hoping that the bill that shows up in your mail was the $10 TV, not the $10,000 TV. So that's, I think, one. Then there are all sorts of the derivative effects of getting better preventative care. All of a sudden you're on top of things before they become an issue, before they become super expensive. So those are a couple of thoughts on. Well,
and I agree with the thesis that it was going to save you money, but I think just on the surface, people presume that if you pushed cost share to the employee, it was a whole predicate of a high deductible health plan is you're a better consumer. Now you have skin in the game. The reality is we put so much skin in the game that it prevented people from going to the doctor in the first place. And then they end up with catastrophic situations that could have been prevented most likely, or a disease state that could have been caught earlier. So I actually think most employers are obsessed with that cost share and making sure employees actually pay their fair share. And they don't realize how much of an impediment to care that's actually creating, where if they just remove that impediment to access, they would very likely save money just like you did on the other side of that. And I think we need to retrain the entire industry to stop thinking along those lines. I mean, I'll give you a use case. We're looking at an employer right now to come in the captive, and I can't say who, but I think they've driven their deductible all the way up to $5,000 or $6,000, and this is a provider as well.
Yep.
And they've seen a precipitous drop in enrollment as well, and yet they want people to be on the plan. Well, it's like, how long can you continue to shift the dollars upward in what you charge your employees to consume care before nobody wants your plan whatsoever? And they're stuck in this negative feedback loop that you have to stop in your tracks and you have to change course, or otherwise that plan's going to just implode, unfortunately. And so if we could move to a world which you set up, which is not just in pockets, you might be able to waive your deductible or copay because you had an outpatient procedure that was covered, to truly your plan had no impediment to access care whatsoever. I actually think we'd see a massive savings as a result of that.
Yeah, I mean, you think about today's plan design, and when last time you went to the Apple store and bought something, did you remember that part of your benefits at employer, you probably had some sort of discount at Apple?
No.
I mean, that's just one example of like thousands of things that are embedded into the plan design of like, there's a little carve out here. If you do this, if I'm incentivizing you to do that, like it's gone to a point where us as patients, we just can't navigate anymore. We throw our hands up, and as a fact, now we have to hire a whole nother industry, which is care navigators.
Yeah.
Just help you figure out how to navigate that. And I think we've seen that when you simplify that, not only as an employer, yes, I've been in the industry many, many years. I've seen in fact, I was one of the first people in America on a high deductible health plan.
Oh, wow.
I was at United Healthcare at the time. We made a big acquisition. We became the guinea pigs of the stuff we were doing. So I've seen that. And we had a premise, I think academically and theoretically, those models they're sound on paper. But we've seen in the industry, they are blunt tools at best at driving and changing behavior.
Yeah.
And to your point with the employer mentioned, which is not unusual, we've now worked ourselves back into the corner where we have nowhere else to go. And Nomi, and quite frankly, we in this model that's in some cases a bit radically different, really it causes you to step back and say, what are the right levers here? We moved to this zero copay, zero deductible model, and we're seeing way better results than we ever did with the HSA, HDHP, or the narrow network perspective. These other tools that we've been using in the past.
Well, but collecting your $2,000 or $3,000 or $5,000 extra here and there from the employee share versus, that's kind of this not seeing the forest for the trees, because that's a nominal amount of money to collect versus the $300,000 you might have saved if you prevented a cancer being at stage 4, as an example. And you have to think about this too. There's a relative inelastic demand for emergency services. You get hit by a truck or you have a heart attack, you're going to go, and there's no choice. There is a definite elastic demand for primary care or for routine procedures. And if you throw $500 or $1,000 in most people's way, they won't get that procedure or that test, even though they probably should, right? So let's just wipe that away altogether. And I would love for more employers to follow suit. I think the underpinning, though, is you have to have the framework to be able to do that, right? You can't just turn around tomorrow and everybody gets a $0 deductible plan. You have to have it set up correctly. You have to have the right payment rails and the contracts in place in order to do that, right?
Well, and it's probably a little anecdotal, and some of you probably won't believe me on this, but I was just visiting one of our states, and I was at an event, and after the event we had lunch, and I was sitting there with one of the head of benefits for one of our customers who's now been a customer for just about a year. And I was like, so how's it going? And most of this was just my nature of wanting to understand where we can get better, where we can improve, are there things that we're not aware of that we should adjust? And she said, Josh, I want to start with, I have never in all the years I've been a benefit leader, which has been many. She's like, I showed up at our next re-enrollment and I got a standing ovation.
Really?
I was like, a standing ovation? She's like, I'm like, tell me more about this. She's like, I showed up and our employees have been so happy with this Nomi approach, with the partners we have at the table, that I got a standing ovation for such a fundamental change in their experience around healthcare benefits that they stood up and clapped for me.
That's awesome.
Now she's like, I can't take all the credit for that. So I just found that I was like, wow, I honestly, I can't believe, I don't think I've ever heard that in the industry. That someone having that experience. We also had another story with a woman who was on the benefit plan, Something terrible happened. She ended up at the hospital. Her mother called on her behalf the call center team and said, "We got to get her out of here at the hospital. We don't have money to afford this. I hear about the costs being run away. This is going to ruin our family." And the conversation went through the process was like, "Well, actually, no, don't worry about it. You have no copay and no deductible for this." The mother broke down in tears on the phone. It was like, "Wait, what?" Like, this has changed my family's life because, the alternative would have been very different had they been on something more traditional.
Yeah, I mean, that's really the crux of this, right? And I think we'll probably wrap here, but there's an emotional element to this, and I could go out and tell all HR directors, hey, you'll get a standing ovation if you put Pareto in place or Nomi in place. But the reality is that the bar has been set so low of what people expect from healthcare or health insurance, right? Those often get intertwined, but it's set so low that doing something better is revelatory, right? Or having somebody be in the hospital thinking, I need to leave because I can't afford it. Although I need to be here, I can't afford it. I got to get out. Go, no, you're okay. You don't have a copay or deductible. You're fine. Peace of mind, I can stay, and I don't have the anxiety of the financial implications. Like, that is the better world that I've been talking about for the last few years, and you guys are obviously delivering on that. And so, Josh, why don't we do this in the interest of time? And we've covered a lot of ground. The floor is yours. Why don't you give us perhaps your closing thoughts or what you want the audience to be thinking about?
Yeah, thank you. I think about it as it's time for us to stand up and make change as employers. We can't, the existing system is unsustainable. We have built at Nomi an alternative, a better path, a new infrastructure, a better way to consume and enrich the benefits and access to that. But at the end of the day, these are real people. I mean, I just shared, a couple stories of like, these are real people. These are real people that work for you and I and organizations that we need these people as a part of our team. And it's time to take the burden off of this runaway cost, buy healthcare and look at the healthcare spend like we do all the other parts of our business, and apply those same economics in a way that we have a better product and solution coming out as employers to be able to provide those people we care so deeply about that we see in the hallways or on the Zoom calls from week to week. The future is already here. This is built. This is not hypothetical. This is driving real and material impact to employers and fundamentally changing the trajectory of their businesses because it's relieving a ton of these runaway P&Ls when it comes to healthcare costs. And so I'd say take action. It's time. It's time, brokers, to take this to your employers and have a real conversation around doing something different and being bold enough to go make change.
I love it, man. That's a perfect place to end it. So, Josh, thanks for coming down. And again, thanks for hanging out with me. And obviously, thank you to Nomi for being a supporter of the show as well. I'm glad we got connected, and I wish it would have happened sooner because I've learned a lot in the last couple hours sitting with you, man. So I really appreciate you once again, and I look forward to the next time we do this.
Likewise. Thanks for having us on. It's been a fun chat.